Well, hello. Welcome to Perfectly Twisted. I'm Nicole Eggert, and this is Dave Palais by my side.
Good to see you.
Good to
as
see
always.
you too. Yeah.
Good week.
Yeah. I spent like 4 or 5 days in Vegas.
Yeah.
Felt like a month.
Yeah. It's Vegas.
Yeah, it's Vegas, but there was a lot going on. It was really fun. And it made me realize it was like I don't know the last time I've been in Vegas sober. Like, it's a whole different world. And it was also very cold there. So there was no, because I was walking around, I was like, what would I normally be doing? And I was like, I'd be at the pool, right? I spend so much time at the pool that eats up the day. And then the not drinking, you really tend to notice more things around you and just like how seedy and how crazy Vegas is. So it was interesting. It's very interesting.
Yeah. You know what? I was there like 6 weeks ago, and what I noticed was I didn't see people smoking, but I smelt a lot of smoke. Like it seemed like, are they piping the smoke in through the ceiling? It was weird. It smelled like old Vegas, but I didn't see anyone walking around with cigarettes. It was kind of strange. You did too?
I did. I saw lots of people smoking, and I smelt lots of people smoking, and I walked into plenty of plumes of smoke. Yes. Yes, it was good old dirty Vegas.
Yeah. There you go. Yeah, it's funny though. 2 days feels like a week, and as you said, you did more than two. Vegas will age you fast.
I mean, yeah, the time can really go. And I don't gamble either, so it's like what to do in Vegas. Luckily, there's a lot to walk around and look at, and there's lots of people watching. And I was there for 2 events, so I had to go back and forth between 2 venues all day long and all night long. So it kept me busy, but
good.
Yeah, good trip all around. But God, it was cold. God damn, it was freezing there.
It was like that when I was there too. Same thing.
Hate it. But today we have an amazing guest. Not too long ago, I was fortunate enough to go out to San Antonio for the symposium, and I got to meet some amazing people. And amongst them, I got to meet Dr. Elenora Teplinsky, and she is online a lot. She is a breast and gyno medical oncologist, and she is very vocal on social media. She has a podcast, very, very interesting, talking about a lot of things that a lot of us, our doctors, are not talking about and are not there yet. So I say go check her out, go watch her videos. She touches on a lot more than what we have time to touch on, but it is so informative, and it's just wonderful to be hearing it. I can't say enough, and it's just so useful. So without further ado, Dr. Teplinsky, please join us.
Thanks for having me. I'm so thrilled to be here.
Thanks for coming on and for sharing. And what I really wanted to touch on with you, because I had talked about going through menopause, and nobody really talking about menopause and perimenopause for us cancer survivors, right? Like we're hearing a lot more conversations out in the wild for women in general, thankfully, but further down that line is breast cancer survivors. And so many are under the impression that we are not to touch any estrogen products whatsoever. I got so many messages about how can you say that, and no way, and I'm on AIs, and I'm doing everything I can to stay away from estrogen. And we're kind of, as patients, we do this thing where we're like, okay, the hot flashes, I guess we're just lucky to be here to have them. And the night sweats, well, at least I'm alive to feel them, and we're under this impression that we just have to live like this. And thankfully, there are doctors out there like you spreading the word that there are some fixes. There are some, beneficial things we can do. You had one specific video where you talked about you had 5 important topics that I find really need to be put out there and pushed harder. And you talked about menopause and hormone therapy, the genital urinary syndrome from with menopause, hot flashes, night sweats, really important is the AI muscular and skeletal syndrome. God, I'm feeling that. And then the excuse my pronunciation, the scarsopinia. Is that how you say it?
Sarcopenia.
Thank you.
You got it.
Thank you.
Yeah, I mean, I think I love what you said. I think there is this sometimes mentality of, and I hear it from my patients every day in the clinic, I shouldn't complain. I should not, I'm lucky that maybe I didn't need chemo, and I'm lucky that my cancer hasn't come back. And I always stop people, and I think we have to decouple that. So I think we can feel grateful, and that you're not living with active cancer, or maybe grateful that you are living with active cancer and it's controlled and stable, but also quality of life really matters. And I think we shouldn't prioritize one over the other. And I think when we do that, then we don't focus on these issues of the joint pain, of the vaginal dryness, of the UTIs, of the mood and mental health changes. And those kind of get pushed to the side because we're so focused on the medicines. And the medicines are critically important, but there's a lot we can do to really optimize quality of life.
Yeah. And it just doesn't really get talked about a lot. And unfortunately, like when I go to my oncologist, it's no to everything. No, 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 no. And then I kind of go against some of the things, and I do take supplements. I do exercise more than what he thinks I should. And I don't exercise that much, but he just doesn't think I should be at all. And then my blood work comes back and they're like, "Oh, what are you doing? Your blood work looks amazing." So it's like I'm this guinea pig of myself, where I'm like, yes, because I feel better, my blood work looks better. I know that what I'm doing is helping. But if I were to ask him, I would be taking absolutely nothing except vitamin D, and I would be overweight, and I would not be exercising very much. When I started losing weight, because I knew that was important, I got a talking to, like, sat me down, like, are you okay? Should we do blood work? Do we think the cancer's back? And I was like, gosh, I don't think, I think the proof is there that being overweight is a contributing factor.
So, and I think that, I'll back up a little bit. We were never taught this in our training. So a lot of times people will say, and I hear this too, no one talked to me about it. My oncologist doesn't know about it. And the reason that I learned about it was because I started sharing on social media, and people were asking me these questions, and I didn't know. So I had to, educate myself. In our training, we didn't learn about sexual health. We had a half an hour lecture on fertility preservation, and that was it. So a lot of this is, hearing from patients who are saying, hey, I need an answer to this. This really matters. But we know lifestyle is so huge, right? There's this whole conversation, of course, happening recently about hormones and breast cancer and hormones in general. But lifestyle is critically important. And that starts with, what are we eating? How are we moving? How are we exercising? What's our stress? What's the sleep? All of these components. And weight is part of it, but even more so than weight, I think what we're really starting to pay attention to is body composition and muscle and fat. And because muscle plays such a huge role in metabolism. And so one of the things that, when people are on chemotherapy, we look at the weight and we always say, oh, you didn't gain or lose any weight. Good for you, right? And we think that that's a good thing. But what we don't actually know is, well, maybe someone is losing muscle and gaining fat. So they're already altering their body composition in a way that may not be as beneficial. And so part of this is really starting to do a deep dive into what's happening inside your body. And I think those conversations are changing and those discussions are changing because we're starting to pay attention to sarcopenia, which is muscle loss. And that can over time lead to loss of strength and loss of function. And interestingly, sarcopenia is associated with people stopping their aromatase inhibitors earlier because they're really struggling and suffering. And so what are ways that we can boost muscle mass? And I will pause here to say that it's not always easy, because if you have joint pain, it is really hard to exercise, and it's hard to find something that feels good. If you have neuropathy and you have balance issues, it is hard to say, well, just go for a walk. So I think we have to recognize where everyone is starting from, and then what are the tools that we can bring in, things like acupuncture and physical therapy, occupational therapy, to help people recover and regain some of that strength they might have lost.
That's very true. And I can be having a great day and I can just be standing there and like just kind of fall over sideways. Like the whole balance is
Mm-hmm.
very real. You know what has worked great for me and is a little rebounder. So I have the little mini trampoline, and you can get them with a handle, and it has helped me immensely. It's also helped me a lot with the movement of my arm after, such a
Mm-hmm.
harsh mastectomy on my left side. It's really helped with the movement. But yeah, and you really have to actively be working on it.
And I think also we talk about exercise. So, the American Cancer Society has these guidelines of trying to work up to 150 minutes per week. And for some people, that may be more, some may be less. But I also like to think about how are you moving throughout the day? So if you go for your 30-minute walk, but the rest of the day you're sedentary and you're not moving, that's also problematic. So we want to think about activity throughout the day, whether that's I'm going to set an alarm on my phone that every hour I'm going to get up and, walk for 5 minutes, whether I have little light hand weights in my office. So if I have a few minutes to kill, I'll do some arms just to kind of keep moving throughout the day, which is also really important to avoid that sedentary lifestyle.
It's a good point because I'm somebody that I hate to sit still for too long because it takes me a while to get up and get moving again. Like I get up like an old person and it takes my body a little bit to warm up. But once I get warmed up and I'm moving, it's great. So whenever I'm sitting for a long period of time, I start to worry. But not everybody has that luxury. Some people have to work or be at a
Yeah.
desk or they have to be sitting. So it hurts. It's not comfortable to sit for long periods anymore.
It's not. Sometimes I know some of my patients who are at jobs where they are sitting all day, they'll get those little little bicycle thing that you could put under your desk if that's an option. Or even just saying, I'm going to walk to the farther bathroom, or I'm going to walk to refill my water bottle. Little things like that, I'm going to park a little farther away in the parking lot. So where are those little secret ways that you can get steps? If you get a lunch break, make a plan to walk with a friend, just ways that you can get some of that movement in throughout the day.
Yeah, I love that. Those are all really good tips. Well, let's talk about menopause and hormone therapy and the do's and the don'ts and the what is available. And you had said that people should be taking or using vaginal estrogen.
Mm-hmm. Yeah, so vaginal estrogen, I think when we think about hormone therapy, there's systemic, which is much more controversial and complicated a little bit. And then there's local or topical vaginal estrogen. And for that, all of our guidelines from the American Urologic Association, from our oncology guidelines, from the OBGYN guidelines, all support the use of vaginal estrogen for patients with breast cancer. And that's because we have a lot of data showing that the absorption is limited. We have data showing that there is no increase in the risk of death with using vaginal estrogen. Now, people say, there's certainly limitations of every research study. There's going to be nuances and biases, and no study is perfect, but we have a lot of data. And we also have data that using vaginal estrogen to treat the genitourinary syndrome of menopause reduces hospitalizations and can improve outcomes. So we're balancing it. There are also non-hormonal vaginal moisturizers. I have patients who are nervous about using vaginal estrogen. They'll say to me, I know the data. I know what you're showing me. I'm still nervous. So then we have a lot of non-hormonal options as well. But really, vaginal estrogen can absolutely be used if you're struggling. And a lot of times we think about this as dryness. And people will say to me, well, it's fine. I'm not sexually active. It doesn't bother me right now. But they've had 3 UTIs in the last 6 months, and we're not thinking about the urinary syndromes and symptoms that come with that. So a lot of when our vaginal and vulvar areas are deprived of estrogen, which happens in menopause, which happens with on medicines like aromatase inhibitors, that tissue gets very thin, it gets very fragile, it's prone to UTIs, it's prone to irritation, pain, discomfort. There's a lot we can do. For some people, they don't find perfect relief with the vaginal estrogen. And part of that is because that area is also innervated by testosterone. So here are where products like vaginal DHEA come into place, because DHEA is a hormone made by the adrenal glands that gets converted intravaginally when you give it vaginally to estrogen and testosterone. So some people find a little bit more relief with that product. So a lot of that is a little bit of trial and error, but working with an oncologist, working with maybe a menopause specialist or gynecologist. Some people will benefit from seeing a urologist or urogynecologist. And then also, let's not forget about pelvic floor physical therapy. Vaginal estrogen is just one part, but pelvic floor PT can be really, really monumental.
Yeah, that's amazing. And that the DHEA, vaginal DHEA, is Interosa, is that correct?
Yes, Interosa, exactly.
Yeah, so ladies, that you can ask your doctor for these things. Is it the same go for women who've had hysterectomy?
Absolutely. So, for whether you've had cancer or not, DHEA, vaginal estrogen, all can be used. And we know that if you're on systemic estrogen and you still have a uterus, you need to take progesterone to protect the uterine lining. If you're using vaginal hormones, you don't need to take progesterone. So that's an important point. But whether or not you have a uterus or not, all of these products can be used.
Yeah. And it's perfectly safe. It's perfectly safe, ladies, and you should be doing it. What also, so as far as like hot flashes and night sweats and things like that, can you talk a bit about that?
Absolutely. So for the right person, there are people who are able or choose to take hormones, systemic estrogen, progesterone. So we'll put that aside for now. But there's so many great non-hormonal options. There's a number of medications that we historically have used off-label, meaning they're approved for another reasons or an antidepressants, but they also treat hot flashes. However, in the last few years, we've had 2 specific approvals of non-hormonal medications that are strictly to treat hot flashes, Veozah and Linquit. These are neurokinin receptor antagonists, and they impact the temperature receptors in the brain, and they are very effective. Veozah was approved a few years ago, and then Linquit is the new kid on the block. It was just approved, I believe, around November. And Linquit may also help with sleep. So for some people, they find that one is a better option. So it's a little bit of nuance. Both medicines can raise your liver enzymes, so they do require liver monitoring, but they can be really excellent options. And what we're seeing, that's at least anecdotally, I'm seeing this, is that it's becoming a little bit more affordable for these medications, which is great.
That is great.
Yeah.
And then what you said was important too about the liver, because a lot of aside from those, even just our AIs and our after cancer treatments, and after going through chemotherapy, we really need to look at cardiovascular health. And I think that really gets left out a lot. I discovered that on my own when I was doing the research on the medications I would be taking. And so talk to us a little bit about that and what can be done, because we do we have high risk of cardiovascular disease when we're on all these medications, right?
Absolutely. And I agree with you. We don't talk as much about the heart as we should. And so there's a couple of things to keep in mind. The first is really understanding what treatments each person has received for their cancer and how they impact the heart. Everything's going to be a little bit differently. So historically, we've thought of specific chemotherapies, anti-HER2 therapies if you had HER2 positive breast cancer, but really starting to understand the impact that the endocrine therapies like aromatase inhibitors have premature menopause for people who go through that. These medications can increase your cardiovascular risk, blood pressure, cholesterol, and down the line, right, the impact of that. And so understanding what treatments you have received, then understanding what is your baseline cardiovascular risk. So do you have a family history of heart disease? Did you already come into this with high cholesterol or high blood pressure or diabetes? And then how are the treatments building onto it? Thinking about left-sided radiation to the heart, that can increase cardiovascular risk. So all of those pieces, and then getting the appropriate screening. So there was actually, I just posted about this yesterday, about using a test called lipoprotein little a, or LP little a, which is a fairly predominantly genetic cholesterol marker that is an independent cardiovascular risk factor. And so we're starting to check that in patients. And I think it can be really helpful. I have found people, I've started checking it And people who we thought really didn't have much of a cardiovascular risk, that marker is coming back really high. And so I'm referring those patients to a cardiologist or a cardio-oncologist to think, what should we be doing to optimize the heart? Looking at things like coronary calcium. So that can be done by a specific coronary calcium scan. But if you've had a CAT scan of the chest as part of your cancer workup or anything else, you can see if there's calcifications in the arteries. If you've had a mammogram that reported on breast arterial calcifications, you can see, are there calcifications? All of these are markers of heart disease and heart disease risk. So I think really understanding what your risk factors are, and then how are we going to screen? How often are we going to check these tests? Do you need a stress test? Do you need an echocardiogram? Do you need to go on medications? And then the lifestyle piece, the things that work for breast cancer also work for heart disease. So not smoking, not drinking alcohol, exercise, healthy diet, limiting ultra processed foods and saturated fats. All of those things are going to have, you're doing double duty in terms of the benefit.
Yeah, I love that. And I saw recent studies, more and more numbers keep coming out about the use of alcohol. The latest thing I read, I mean, I was like, I don't think I'll ever touch it again. Like, I'm so scared of it. And yet it's so readily available and so acceptable. And so many women, drink as they're making dinner, and it's just casual, and nobody really thinks of it as, you don't have to have a drinking problem to, have it contribute to all kinds of cancers they're finding. And it's kind of horrifying.
Well, and the other thing with alcohol, I mean, I think alcohol is where smoking was, however many years ago. But I'm encouraged that the younger generations don't seem to be drinking as much based on some statistics. But I also think one of the things we don't think about is the impact of alcohol on everything else. So I know if I have a glass of wine, my sleep is going to be affected that night. And I may have hot flashes or night sweats. And so then you think about it, well, if you're having a drink or two, your sleep is going to be affected. Now you're waking up, you didn't get that quality sleep, your cortisol levels are higher, you're not feeling great, maybe you have joint pain, right? And it's this, and then we know that when we don't sleep well, our hunger hormones are all over the place. And so you can see this ripple effect. One of the things I tell my patients who are struggling with they're like, I'm not feeling great, I'm not sleeping well, tell them, go cold turkey on the alcohol. Just cut it out completely. Don't even have a drink here or there. And they come in a month or two and they go, wow, like I feel so much better. So even that one glass of wine can have health impacts. Now, again, some people say I'm going to choose to have a drink here and there, and that's fine. I think that but what we know is that nearly half of Americans don't know the risk between alcohol and cancer based on studies. So I think this is important, just talking about what that risk is.
Yes. Besides all the other things that you were talking about and how it's a downward spiral, but it's actually a carcinogen, right? So it's sorry, I'm a little bit slow this morning. Running a little bit late. Everything's coming to me a little bit slow this morning. Yeah, in itself, and that they're considering putting black warning label on alcohol bottles at this point. So yeah, it's definitely something to stay away. Can you talk about the new prescription that could be available, Addyi?
Yeah, so Addyi's been around for a little bit, but there is just bigger push for it because it also just gained approval to be used, I believe, in postmenopausal women. So Addyi is flibanserin. It is a medication approved for hypoactive sexual desire disorder. And hypoactive sexual desire disorder is essentially when you don't have an interest in sex and you're bothered by it. So some people don't have an interest in sex, but it doesn't bother them. So this is where you feel distress from it. And it's important that we rule out other things that could be causing that, metabolic abnormalities and things like that. But assuming that's been ruled out, and we know that a lot of patients really experience that the medicines, the aromatase inhibitors, tamoxifen can impact desire, and people struggle with it. And so Addyi is a great option. Again, initially was approved, I believe, for premenopausal women, and then just got the expanded approval for postmenopausal women. And one of the things I highly recommend, I just watched a screening of the movie The Little Pink Pill. I think that's what it's called, about how Addie kind of came to be and all of the hurdles that they faced, or the Pink Pill film, I think that's what it's called, all of the hurdles that they faced in getting the medicine approved. And one of the crazy things about it was that the FDA didn't want to approve the pill. The pill can cause a little bit of drowsiness, and they thought it would make women too tired to drive their kids to school in the morning, so they didn't want to approve it. Isn't that wild?
Oh, don't even get me started.
But
Yes.
the film is going to be streaming on March 8th, which is International Women's Day. It's so great. I watched it. I thought it was amazing. But so Addie's a great option. And I think one of the challenges is that the way that Cindy Eckert, who is the founder of the pharmaceutical, or led to the approval of the drug, talks about it is, she says, it's not like Viagra, right? And it works completely differently than Viagra, but it gets women from not thinking about sex to thinking about sex. So it's not going to fix everything. And that's been my experience with patients as well. But people feel they do have a little bit more interest. And so I think that's a big part of it. And then as we think about desire, there is spontaneous desire, and then there's responsive desire. And when we're on the hormone blocking medications and menopause, sometimes you lose that spontaneous desire part where you just want to be you want to have sex, and it translates into responsive desire. You get going and things, your body responds, and you have the libido that way. And so understanding that the difference, that the spontaneous desire may change, and responsive desire is also very important.
Yeah, there's a big difference between that. But even when you said that there's such little studies on, just certain things like the estrogen, vaginal estrogen, and it's like, if this were happening to men, and we would have so many more answers, and it would be so much more readily available, and it would not be such a discussion to be had. It drives me bonkers, but here we are.
What's crazy about the Addie approval was that they were using male metrics to approve a female medicine. They were saying, well, it doesn't work the same way as it does in men, but it's not going to. It's a completely different medicine, different mechanism of action.
Yeah, this isn't for you. Sit down for a minute.
So there's a lot. I mean, it's just really fascinating, the history of women's health and how these drugs came to be, and the challenges. It's just a whole other conversation.
Yes. Okay. So also, what about, because the AIs with the muscular and skeletal syndrome? So I feel like I definitely feel the effects of that. Like my glutes are just non-existent. I do my arms. I work out my arms every day, and I try to walk a lot. So it's like, but there's so many muscles that I just see is just shrinking away, and I worry about my bones. But that's kind of the thing, is you go to, or at least I do, it's like, I worry about my bones, but you need to be worried about your muscles as well.
So the aromatase inhibitor musculoskeletal syndrome of menopause is everything that you described: the bone loss, the joint pain, the muscle aching. And the part that we really want to keep in mind is that muscle and bone work really integratively together. So this is why there's such a big focus on strength training and trying to lift weight, whether you start with your own body weight and then work up to it. But when we lift and when we strength train, that creates little tears in our muscles. And as the muscles repair themselves, they hypertrophy and get stronger. And that puts more force and pressure on the bone. And then the bone builds, and then that releases proteins that stimulate muscle. And so it's this positive cycle. But with AI-MSS, or the musculoskeletal syndrome of menopause, with aromatase inhibitors, we get the bone loss piece. So we recommend a baseline bone density before starting, and then every 2 years. And then, of course, calcium, vitamin D, bone medications if needed. And then with the musculoskeletal part, it can manifest in different ways. Some people say I feel achy and stiff in the morning, but other people say I feel achy and stiff all day and I just can't ever get comfortable. So there's a lot of things that we can do. Sometimes we do have to change the medicine or take a break from the medicine. Sometimes if there's specific areas that are causing discomfort, so people can get frozen shoulder, they can get carpal tunnel, they can get rotator cuff. So site-specific treatments or carpal tunnel, like wrist injections or splints, or frozen shoulder, like acupuncture can work really well. So site-specific things can be helpful. Movement, exercise, and there are some supplements that can help. But it's really a multifactorial approach. And I love, again, bringing in some of these complementary therapies, PT, OT, acupuncture, and others that really, really can be helpful.
Yeah. And it does. And for a while I was feeling great. And then now it's gotten back to where I wake up and my left hand is stiff and, it takes me a minute to get moving again. And I'm not quite sure where there's so much to balance. I'm not quite sure where it all went left again, so it's this constant trying different things and just keep at it. And I think that that's so important because it's so easy, honestly, to give up and just say, oh, well, this is just the way it is. And it's just so hard. And, this is just what I've been dealt. But all of these things, it's not just uncomfortable. These things lead to for bigger problems down the line.
Mm-hmm. And it's a lot of work. I mean, it's easy for me to sit here and say, well, do this and do this and do this, right? But all of this takes so much time and money. None of these things are cheap, right? A lot of these things aren't covered by insurance, and you have to find the time to go to physical therapy and pay for acupuncture and, all of that. So I think understanding, really hopefully having a team that can help you with some of these side effects. One of the great things that I do recommend doing is asking if your medical team or sometimes the gym or has access to those body composition analyses, like an InBody machine or others, just to try to get a sense of what's happening with your muscle mass and fat composition. That can really be helpful. We're seeing more patients use the GLP-1 medications, and there is some very early data, very, very early, but promising that they may impact breast cancer recurrence. Again, very early, and we don't know if that's because they lead to weight loss, or if they're impacting due to impact on insulin resistance and inflammation and metabolism. But that's certainly something that is being actively studied, which is really exciting.
Yeah, I read some of that too, which and you hear so many cancer patients say that. And we read it's good to keep your weight down, but then it's such a hard time in life to keep your weight down because you're menopause and no estrogen and you feel lethargic and all of it. So it's it seems almost impossible to get the weight down. So the GLP-1s, I think that's so amazing and so promising to read.
Yeah. Mm-hmm.
Yes. So you have a podcast, correct?
I do, yes. Mm-hmm.
Where can everybody find it?
Yeah, so it's called Interlude, and it's on Apple and Spotify and wherever you listen to podcasts. And I share stories of people affected by cancer, not just breast cancer. I talk to experts, so lots of different stuff on content there. But I love it because it's a great way to talk to people, survivors, thrivers, about what their experience has been. And sometimes I think the internet's a great place and support groups are a great place, but for some people they can be a lot. So just hearing everyone's story individually can sometimes be helpful. And I also have a book coming out in September called Beyond the Pink, which highlights a lot of what we just talked about, but it's really a patient-centered guide to all the things you're not talking about with your doctor because there's no time. And so we, in the book, I talk about bone health and muscle health and sexual health and mental health and all the things that are really important.
I love that. Yeah, because sometimes too, when we go into the doctor, we're like, okay, we're going to talk about this. And then somehow we get sidetracked and then our time is up and it's over.
Mhm.
Or we're confused as to like what symptom goes with what and what we're feeling. And one day we felt that. And then today we're not feeling it. And it's like, is
Yeah.
it worth it to bring up? And there's just so much to balance out and, prioritize when you do have that limited time with your doctor. So books and
Yeah.
podcasts and your Instagram feed, it just, all of these things are so helpful to remind you and to keep it in like, oh, I'm not alone. And okay, this is something that's happening and it is related and there is something to be done. It's just so incredibly helpful. I love social media for that. And
Me too.
thank you for doing it because you are so good and consistent and up to date with all of the things. And also you were talking about being tested because everybody's getting younger and younger. This isn't just an older person's
No.
disease anymore. And so she talks about ways to ask to be tested if you have suspicions and reasons and asking the doctors why not to be tested. And I just think that's really important because I was really blown away by how many young people were in my treatment facility when I was going. It was heartbreaking.
It's getting younger and younger, and the incidence is rising, and yet so many people are being dismissed or not being taken seriously. And I think it's hard, and I think we underestimate. I mean, there is a vulnerability when you go to the doctors as the patient, and if the doctor is saying to you, you're fine, right? How do you, sometimes people say, well, they said I'm fine. I don't feel fine, but they said I'm fine. And so I really try to encourage people that if you feel something, your body the best. So if you feel that something's wrong, bring someone with you if you can, have them on FaceTime, have them on the phone to really push and really verbalize your concerns. I am concerned this is cancer, or I am concerned my cancer is recurring. Say what you're worried about just to put that out there. It's scary to do, but if you put that out there, I do think hopefully that will help, with that advocacy a little bit.
Yes, and when you're right to have somebody with you, sometimes it's easier to speak about things, or you have a little bit more encouragement, and you have a second set of ears to hear what the doctor says. So that's beneficial in so many ways. Yes, so you can follow Dr. Teplinsky on Instagram. You're at just your
Dr.
name, right?
Teplinsky. Yep.
Okay,
Easy,
love it.
easy.
Yeah, Teplinsky, and check out the podcast. Unbelievable. Thank you so much for all that you do. It's just so important and shedding a light on all of it and not making us feel so alone and helpless and hopeless and all of those things.
Well, thank you so much for your work and your advocacy. I think these conversations are so important, and thank you for including me in them. I'm really honored.
Thank you.
Very, very informative. Again, I enjoy these shows because I always think you're doing such a service, that you find the right people to put on to share information.
Well, because I flip through videos and things all the time, but then you do find certain people who are like hitting the nail on the head every time. Right. And, and addressing the things that we're not hearing about or we're being told no to. And, and she's, she's the real deal. Like she's an oncologist. This isn't like some health guru telling you to do this and that. You know what I mean? This is coming from a real medical professional. And, that's when you perk up and you're like, okay, there are things out there and it's forever changing. What was true, last year is different this year and next year will be different. So it's really important to stay on top of all the treatments. And like she said, the two medications for helping with hot flashes and night sweats were just recently, greenlit and approved for those when they're really for other things. So many medications people start taking and they're like, oh, it helped with this and it helped with that. And then, by 2026, they're approved for, hot flashes and night sweats, which is so important to deal with. So yes, it's important to stay on top of it. And when you have doctors like this and you have the internet, it makes it so much easier.
Yeah, absolutely. Yeah. Absolutely. Do you want to finish the show with the mailbag?
Sure. Let's do it.
Okay, let's get to the mailbag. Again, if you have a question for Nicole, you want to get your questions on the show, go to perfectlytwistedpod.com. At the top of the screen, it's Nicole's mailbag. I have two different people actually who are going to share the mailbag today.
Okay.
We have two from Esperanza Anderson. Her first question is, Nicole, what was Aaron spelling like?
He was great. He brought me in for everything. And he would give me a lot of work. It's interesting with Aaron because he never put me like on one of his big hit TV shows as a regular, but he would keep me working all the time on guest spots on other shows. And so I was always traveling and always working. But we never found that like one perfect role for me on any of the hit shows. So I kind of like, I missed the mark with him. He was sort of like an Al Burton for me. Al Burton was the executive producer on Charles in Charge. But Al and I found, the part, which was Jamie. And Aaron Spelling was such a kind man, an honest. I felt like he was being honest when, a lot of these people aren't. You go in and they're like, you're great, you're great, you're great. And then they like, oh, nah, not going to happen. But he would tell you like, I don't think that this is the right one, or gosh, I'm keeping my eye open for you for something. And he always kind of felt like I was, he compared me to Heather Locklear a lot. Which always was such a huge compliment. And he did give her a lot of leading roles. But I really liked Aaron Spelling and really cherished him, and felt like it was a missed opportunity in some ways.
All right, next question. Nicole, if you could go back and relive any time period of your life, what would you choose? For example, your 20s or when your children were small, what was the time period you'd go back in?
Well, there's so many. There's so many there. I mean, I think that I would. It's interesting because I guess the younger you go back and change things, then I guess the more you would change later years, right? So if I went back to a very young Nicole and stopped some of the trauma and, had her speak up and not carry so much trauma, maybe I would have been better at other things later and more able to deal with things better later. So I guess that's what I would do. I would start when the trouble started. Exactly. I would go back in those areas and be like, okay, this is enough. Speak up. Don't put up with this. Let's deal with this so that later you can have a different kind of life and be a different kind of mother and all of those things.
All right. The next three from Lisa says, Nicole, was raising your kids harder or easier than you thought it would be?
Well, that changes. I think it's definitely harder. It's harder. And all the years that they grow, it becomes harder and different. And, they have their feelings and they have their perspectives, and you have to take that into account. And you realize they never are going to realize how much you love them and how much you care about them until they have their own children, if they have their own children. And, they love you deeply, but it's not exactly reciprocated. It's different. We love you so much more than you understand. And I feel like, so there's a lot of difficulty in that, but then there's a lot of easier in that I didn't know that they would bring me so much joy and teach me how to love and give me so much love and make me feel so deeply. So it's a bit of both, really.
Next question. Nicole, have you ever stopped being friends with someone because they were negative or pessimistic?
Yes.
Yes. Me too.
Yeah. And it, just some people just take the negative spin on everything. And it's such a drag to be around, and it just brings you down, and then you're in that negative energy sphere, and I don't want to be in that. I try to get away from that. And so absolutely, negative Nellies are out the door.
All right, last one. Nicole, who is your favorite rock band?
No, this is not a question. There's no favorite rock band. I am not that person. It depends on the day. It depends on the hour. It depends on the mood there. And what do we consider a rock band?
That's true.
I mean, I love I love Rage Against the Machine. I also love the Beatles. These are very different genres. I love music. I love rock bands. And that's the only way I can really answer that is that. And then there's some songs I love from certain bands and other songs that I don't. It's not. So I am not a huge fan of just one particular band.
Okay.
I love Black Sabbath, but I also love Pearl Jam. I love Soundgarden. I don't know. I love a lot of bands. The answer is yes. I love rock bands.
Nice. All right. So Esperanza and Lisa, thank you so much for this week's questions. Again, perfectlytwistedpod.com to ask Nicole a question. Right there, the mailbag is on the top of the screen. You can get
Yes, and we love it. Thank you so much for your questions. They always add such fun to the show. And give us a like, a subscribe, a follow, a comment, all of those things. We love you, and we will catch you next time.